Welcome to A Window on SAHMRI, where we take you inside South Australia's independent not-for-profit health and medical research institute. Each episode, we get to know the people driving our life-changing research, getting into what motivates them personally and how their work is delivering a brighter, healthier future for all.
David, can you please start off by telling us a bit about your role as a clinician?
My name is David Yeung. I'm a haematologist at the Royal Adelaide Hospital. And as you know, Callum, I'm also a leukemia researcher at the SAHMRI, the big cheese grater. So I've been a haematologist for almost close to 10 years, a bit over 10 years. And early on in my career, I actually met Joe. Joe was actually one of my first patients. So maybe, Joe, tell us how we met. What was it like from your side? I remember what it was like from my side. I was more calm than you, I think.
I think you were, yes. Hi, Callum.
Hey, Joe, when was that you met David?
That was 8th of October 2010, and it was school holidays at home in Whyalla, and I had my son at home and he was ill with the flu, and I'd been to a doctor, had a routine blood test for, I can't remember what now. The doctor who ordered the blood tests went straight off overseas on holidays, so my results sat in limbo for quite a while. And by the time someone from the RA called me at home and said, you need to get to hospital, I was like, why? Because I was 100% perfectly well, I thought. And I said, when do I need to come to hospital and why? And she said, well, you need to come today. I said, I can't because I've got a sick child here, which was like a red rag to a bull saying that, because I didn't even know why. And she said, look, I'm not supposed to tell you, but I'm going to tell you you've got leukaemia. I didn't even know what that was. So
how did you receive hearing that?
Oh, well, actually my stomach probably fell out on the floor. I was just, because it just changed my life instantly with one phone call.
Did you believe it when she said that?
Yeah, I believed her. I didn't understand what it was, but I believed her. I had several phone calls from pathology and the hospital before we found out what it was, and I had no idea what anyone was talking about. My GP couldn't find any information, so he said to me, don't worry about it, it's probably mix-up of results. But it wasn't, it was my results. So I rang my husband, he stopped work. Lucky we were in a position where he stopped work for 4 months, and I think the next day I met you.
Yeah.
I was a mess.
Yes. And I think it's, as Joe has said, this is in the younger patients, when patients are diagnosed with leukemia, that's the phone call that the doctors often have to make. And we often find it very difficult because imagining from Joe's side, you're called by someone whom you've never met, and sometimes the call even comes out as a private number, and you go, is this a prank? So someone you've never met said, you must come to the hospital right now, and I must imagine it must be very difficult on your side. And I never know what's right to do, because sometimes I think to myself, should we actually get them in here, sit them down, give them a glass of water, and then go through things? And I guess that's ideal. But if we did that, some people might did whatever Joe just did and say, look, I'm busy. Can you just get over and done with and tell me why you need me? And then we're forced to actually tell somebody, I think something is seriously wrong. You got to come round. And then you worry about them driving like a maniac down the freeway, trying to get in. And so I don't.
Such a delicate situation to try to manage, and there's no good outcome. There's no good way of telling people that they have cancer, is there?
That's right. So I think despite all the medical schooling, we say, look, do it like this. In reality, most of the time is a bit of be gentle, be compassionate, be considerate, and try to get it done. And then, as Joe said, the next day she came down, and then And then there's another bombardment of information, what's leukemia.
Do you remember your first conversation together, and David, you telling Jo more about her condition?
I must say the things that I remember us talking about is actually her family, her kids, husband, and her situation. The leukemia itself, I'm sorry, it just blurs into one another because after so many cases of
it's understandable.
I can't remember. All I can remember is I'm just happy that you're doing so well now. But
me too.
But Jo, it was AML.
Yeah,
that's right.
So can you tell us a bit about that form of leukemia in particular? Probably David, not you, Jo.
Yeah. So I guess the important thing to know is that inside the bone marrow are stem cells that make blood cells, which are red cells, white cells, and platelets. And in normal human life, those cells get replenished all the time from the bone marrow stem cells. And when something goes wrong with the stem cell, a genetic change that causes leukemia, this is SAHMRI, so let's go a bit scientific now, there are often blocks in differentiation, so that cells that are supposed to mature into normal cells don't, and then they get these blocks in differentiation that holds them at a more immature stage, useless, immature blasts. And when those cells get up to a certain percentage, we call that acute myeloid leukemia. There is another type of acute leukemia called acute lymphoblastic leukemia, and they are very similar in appearance under a microscope to AML, but the mutations that lead to ALL are very different. The mainstay of treatment when Jo was diagnosed was combination intensive chemotherapy. It still is for many of these acute leukemias. And at SAHMRI, we've got good research programs in AML and ALL, both. I work on the ALL side. But one of the challenges when we meet patients with newly diagnosed AML is to actually get across all the information about leukemia in relatable, bite-sized, comprehensible chunks. Because I imagine Jo, patients, Jo, would have been freaking out at that point. Oh my God, what are you telling me? I've got blood cancer.
Tell us a bit about that moment, Jo, in that time in your life, shortly after finding out it's real. You come to Adelaide, you meet David. This is all swirling around you. What do you recall about all of that happening?
I remember sitting in that room with you, and there were a few other doctors there as well, and you explaining to me in the best terms you could what it was, but I couldn't take it in. And I remember when it was all like the consult was finished and it was all, this is what's happening, I did look at you and say, but you can fix it, yeah?
No pressure.
No pressure.
You can fix it though. And I remember David looking at us like that, and he said, yeah, we'll do it. I'll do my best, like that. And that's when I thought, oh, maybe it's not fixable.
What's it like to have a patient look at you, David, and say that, and then to have to respond, and you know that you can't 100% say, yes, it definitely can. You can say, I'll try my best and we can hope for the best. But, to look someone in the eyes who's potentially facing death and have to respond.
Yeah. I think as I get on as a hematologist, I'd like to think that I'm a little bit better at judging that interpersonal distance. Some patients are very methodical and very exacting, and they want to have everything, all the cards on the table. And without that, they just won't stop thinking about it. Whereas others just want that reassurance and say, look, just tell me it's going to be okay. I don't care how you do it, just do it. So I think, just as there are very many different types of people, I think the approaches that we need to take is very different. The second thing is nowadays, even compared to 10 years ago when Jo was first diagnosed, there are a lot more things we can do now. So I think both us as medical professionals and And for the patients and their families, the conversation is a little bit different, is a bit more optimistic, is a bit more hopeful. And the things that we can do to make chemotherapy less horrible is also much more advanced. So I think, having that conversation now, I think it is still unpleasant. And there are still things that patients will need to go through. But I think having that trust is an honor for me. Somebody or their family saying, I'm trusting you, can you make it better for me? So that is one of the ultimate honors of being a doctor.
What was the reality of Jo's chances at that time?
Oh, I think even thinking about what we could offer then, I think her chances of a remission is actually pretty good. So in AML now with combination chemotherapy, intensive chemotherapy, the odds of getting into a remission is 70 to 80%. The problem is not getting a patient into remission. The problem is actually, one, for those patients who are not fit for intensive chemotherapy. If you're older, if you're 85 with heart disease, for instance, you're just not going to be able to withstand that chemotherapy. So those patients may not have as good a chance of getting into remission. The second problem is once a patient gets into remission, we need to do extra work to keep them in remission, preventing relapse. And in some patients, that may be extra chemotherapy. In other patients, it may be a stem cell transplant. What we're moving towards is a future where we can use less toxic chemotherapy, use targeted agents, small molecule inhibitors, oral tablets to try to, if we can actually have drugs that work better, we don't have to use as much chemotherapy, and patients won't get as many side effects, and even less fit patients can benefit from those approaches. That's the first thing. And the second thing is if the therapies get better, then maybe we can use less or chemo, or maybe we won't even have to do stem cell transplants anymore to keep people in remission.
Tell us about going through treatment.
It's pretty horrendous. I really struggled with all the massive tests that are done prior.
Yes.
I didn't even know they existed because I was maybe used Band-Aids and Panadol before I went into that world.
That wasn't going to cut it.
No, but I wasn't on medication. I was never sick. So to go from 0 to 100 and then get into, it's a world. And I must admit, I found that I was quite good at giving myself over to it. And like David said, it's the trust factor. So.
And you trusted David?
Oh, absolutely. 100%. That's what I was saying to you before. I loved hearing his phone ringing down the corridor. I knew he was coming. And just that reassuring face, that person, that doctor that walked in my door made all the difference.
What was it about David's manner that made you trust him?
He was just honest and open and friendly, and he laughed. He was just easy. He was. Yeah, I still find him the same. I just feel like I've got a connection with him almost, even right from the start. It was a huge degree of trust. Absolutely.
I think most Australians do react like this, though. We like to take our bad news with a pinch of humour. So we
don't laugh, you cry.
That's right. Although it's funny, one of the other patients that another specialist sent me for a second opinion, he didn't like me very much because he thought I laughed too much.
Whereas I like that.
Sounds fun at parties.
But I think it is something that takes a lot of strength of character from a patient's perspective to actually put up with everything that we ask for, because as you said, Jo, you sit me down here, you're telling me something that's completely going to change my life, and the next thing you've are going to tell me is that within the 24, 48 hours, you're going to stick needles into 5 parts of my body. And then you're going to tell me that I'm going to lose my hair. You're going to, tell me that I'm going to stay in Adelaide in this room for the next month, away from family, away from friends in Whyalla. I don't even know who's going to take my kids to school the next week.
That's right.
And
Total loss of control.
You leave all that
that's
behind.
right.
Yeah.
And it's just very, very challenging. And in South Australia, unfortunately, I think we centralise medical services. And there are many things that we can't do, even though the government says we want to offer care closer to home. And intensive combination chemotherapy is one of those things that we just can't deliver in the regions. And I do think that it, for people like you, Joe, from regions, is actually makes it extra hard because, as I said, you live in town, but there are some of our patients, they actually have animals. They think, look, who's going to feed the cows?
Yeah, right.
And when I say, look, can you come down at 9 a.m. on Monday? They say, well, there are no planes at 9 a.m, Doc. What are you talking about? Yeah. So I think that's one of the things that going forward in public policy, we need to be more mindful of at a structural level.
Yeah. How
long did the treatment go on for, Joe?
Well, when I got called to pack a bag, I said, well, how long for? I'm pretty busy. She said, 2 weeks. I went, what? I can't take 2 weeks out of my life. So she said, just come down and we'll make a plan. And I got home in 4 months. So 1 month, like David said, is pretty much locked into a room. You don't go out the room. No one comes in. Well, a lot of people did come in, but it's medical people coming in. And 4 months before I got home. And I think at that very last blood test and waiting for David to come in and tell me the numbers, because by that time you get pretty good at knowing the numbers, and the cutoff point was 4. And he said, if the number is 4 and up, you can go home. If it's below, you have to stay and have more treatment. And my number, of course, was 4.0.
I think
that counts.
Yeah.
And you said, I really would like it to give you another round. And I zipped up my bag and I refused. I said, thanks, but no thanks. I'll take my chance.
4 was the lucky number.
I couldn't. If it was 3.9, I'm sure he would have made me stay. But
yeah.
And leading up to that point, there was that 4 months there.
Yeah.
How rough did it get for you, Joe? Because I remember you telling me earlier that you had times where you weren't sure if you were going to make it.
Yeah. Yeah. I picked up a couple of infections and was given a couple of high-end type of drugs, but I had a reaction to them. So that put me in ICU. Were you in the country when that happened?
Yeah, I was. I was doing my research role then, but I remember that there was an unfortunate complication where there was a bug that actually went into the muscles of your thighs, and we had to have the surgeons involved and multiple ultrasounds and Lance, a couple of boils. And yes, you're right, you had an allergic reaction to one of the antibiotics that we had to give you. Unfortunately, this is one of the more common complications to do with treatment with acute leukemia, and that is loss of immunity during the period when just after the chemotherapy and easy infections. And as you said, you got very sick, Joe. Being a bit younger when you were first diagnosed, you actually had a lot of physiological reserve to deal with it. If it wasn't, your normal healthy living lifestyle, I suspect you would have taken it even worse. So I think when people say, look, why does it happen to me? I've always lived a clean and healthy life. It is true that there are some environmental factors to actually increase your risk of leukemia. There are also some familial factors now that we know will increase your risk of leukemia. In fact, the link between certain genes and acute myeloid leukemia, one of the earlier groups to work on that is actually a group down the road from here, Hamish Scott's group at SA Pathology. But besides that, the majority of acute myeloid leukemia that we see is actually what we call de novo, especially in young people, i.e. there's no particular link to job, environment, or family. In the older patients, as we age, we all get mutations in the background, and the risk of AML increases gradually. There are, as I said, obviously some risk factors that increase your risk of acute myeloid leukemia. One of them is prior exposure to chemotherapy. And one of the research groups that works out of the SAHMRI is Devendra Hawasi's group, which actually is looking into post-chemotherapy acute myeloid leukemia syndromes. So these are young women, young men, young women who've had chemotherapy for another cancer. So, for instance, we've got a girl coming into us who's had Hodgkin's lymphoma, who's had chemotherapy, got the Hodgkin's wiped out, and unfortunately the chemotherapies increased the risk of later cancers, and she's coming in for her treatment for acute myeloid leukemia. That's not common, but it is an increasing problem as patients are living longer, and the treatment that we give to treat the first cancer is increasingly effective. So then paradoxically, it's led to an increased opportunity to actually look for other complications.
How did you get Joe to a 4?
Well, I think just coming back to what we're talking about, what Joe's describing is when patients are shut into a room for 4 weeks, they really, really want to go home. So what we tell patients is we've got to have 2 things, right? The chemotherapy's got to have done its job. So therefore, the blast count has to be less than 5. So that's why she says it has to be a 4. And a neutrophil count, or the good white cell count, has to come up. So those are the 2 things, especially when you're going back to Weiler, I need you to be bulletproof, you know? So then the chemotherapy would have actually reduced the blast cell count down to less than 5%. And we call that a remission. That's a really good result. And then, but I say to patients, paradoxically, unfortunately, because you've got such a good result, I need you to come back for another round to actually get it down even further. And that's when patients
Some patients refuse.
No, they don't refuse. They say, I really need a break, doc. I'm going. I'll call you back in a couple of weeks, right? So, and that's absolutely how we do things, because otherwise people just get cabin fever.
But then, Joe, you've been in remission now for 14 years and drug-free remission and happy and healthy, and seems like a fairly miraculous recovery. David, I'll get your view on the fact that Joe's here now with us and telling her story. Is that, how common is that kind of a recovery from that level of cancer?
I think it's increasingly common. It's hard to generalize now because, as I said, even with acute myeloid leukemia, there are now multiple types. We do know that with some types, the survival rate over the long term is 85-90%. It's rare to get one of those subtypes, but they do exist. And then at the other end, if you have an acute myeloid leukemia after another cancer, the survival rate is, as low as 20 to 30% long term. So we're working at both ends of the spectrum to make sure that everybody benefits from future therapies. But, Joe, I think if I were to see another patient with your case again, I would probably still offer the same treatment. And the overall outcomes is, over the long-term survival, is probably about 60 to 70%.
What do you think of those odds, Joe, and then the fact that you're in that 60% and you've managed to make it back from all of that? What do you owe that to?
Definitely the research that goes on, and I'm forever grateful. I'm grateful a lot, like daily. Sometimes when you're having a hard day or a bad week or whatever, I really stop and think, could be worse, and I'm here. Yeah, I often think about the research, which has kept me alive, and it's helping so many other people as well, that without it, I certainly wouldn't be sitting here. Yeah, I do listen with interest the percentages of people who make it or don't, and why did I, and all that sort of thing. It plays on your mind a lot, yeah. I talk to people that have cancer, had cancer, but I've never actually come across someone survived AML. So maybe you could put me on to someone.
I think that's something that we need to be very mindful about, and that's survivorship. And I must admit, this is one of the current areas of need of the current system, which is, once we actually given the patient their treatment, we say, look, you're cured, go back to doing what you're doing. The post-treatment psychological support is lacking, and that's something that we've known for a while. Another thing that we need to make sure we do is, as we said, chemotherapy actually increases the risk of later complications, heart complications, lung complications, cataracts, cancers. So now what we do with survivors is to make sure that at the very least they need to look out for later on problems and actually try to fix them. But as I said, the psychological support, the survivorship, I think that there's a lot we can do in that space to improve the quality there. In children and young adults, I think they're doing better. Michael Osborne and his youth cancer service actually has psychologists and social workers embedded to make sure that young people after the cancer during the cancer treatment and after the cancer treatment has that appropriate support to reintegrate into social life. And but for adults, I think we just say, look, we're done. Go on your merry way. And I think, as you said, Jo, is probably not quite as easy as that for many people.
That's right. And to be honest, when I got out of that hospital and drove home, taken home, I did not want to think about hospital treatments, needles, anything. I just wanted to go back to normal, whatever that was.
Fair
I
enough.
wanted to go back to work. I wanted to just get on with my family, because I forgot I had a 10-year-old son and a 21-year-old daughter at the time. And I just wanted to get back on being involved with their lives, running my household. I just wanted to go back to normal. I really did. I just wanted to shut it all off and just get on with it. And I remember calling David and said, I want to go back to work. This is 7 months after my diagnosis, at 3 months after I'd got home. And he said, no. And I said, but I really want to just go back to normal. In hindsight, I wish I hadn't. And he said, look, I didn't want you to go back to Whyalla, and now you're asking me to let you go back to work, back in industry, the Whyalla's industry. And he said, no. So I went back to work, and life went on. But then always in the back of my mind, I'm thinking I wasn't quite ready to leave it all behind, but I'd left it too long to find out how to get back involved in it in some way. Like I almost wanted to talk to David again about what had happened, and I wanted to talk to other people who'd been through it. And
so it felt like you didn't fully process it.
Yes. I shut it off, get back to normal, but I shouldn't have. I should have taken a bit of time and processed what happened. And
why do you say that?
Because I'm still, after all these years, still wondering why I didn't do that. You still
have questions about it. You still want to talk about it.
I want to
That's very
see my
normal,
file.
I imagine.
Yeah, I want
David,
to read my file.
to go through something.
Can I?
Of course.
To go through something so massive, yes, and then to come out the other side of it when you might not have, and then to be expected to go back to normal.
Yeah,
it's a big.
And it's lovely to go back to normal. It is. It's great. How lucky was I? I got to go back to normal.
Yeah. And I think it's, and I don't mean to put it quite like that, but it's you know how if you've been through something that's really important, you got the pictures to show for it. It's almost like that. I want to see the pictures from back then and see how I got through it and what actually happened. And that was a blur. And I think
some of it is a blur.
Yeah,
because it's important that it did happen.
Yes,
you made it through
right.
it. And it's, as much as you want to forget it, you don't want to forget it.
That's right.
Yeah, you can't forget it.
Yeah,
you can't forget it.
And why did you decide to work at SAHMRI?
Well, I moved from Whyalla to Adelaide 3 years ago. And after about 5 or 6 months, I thought, I better get a job. So I started looking through Seek, and I was scrolling and I saw the SAHMRI logo flit past my screen. So I quickly reversed and looked at a job there, and I thought, well, that's exactly what I can do. I won't get it, but I'm going to apply for it because I love SAHMRI. I love what they do. I knew David's connection. Why wouldn't I apply? I just wanted to go. So I went and applied and I got the job. So that's why I applied for a job there.
There's a nice synergy there.
Yeah.
It's a place that means so much to you.
Yeah, that's right.
Yeah.
That's right.
Yeah, well, I think it's the perfect show. It's the perfect story to show translation of research into impact and the difference that our people, David, can make in the lives of others like you, Joe. And I think it is an incredible story, and I think it is really important that you get an opportunity to be able to share that because you did go through it, and so many people are going through that now or something similar, and there is hope and there is life on the other side of that.
Yep.
And it's I don't know you very well, but it's really great to know this about you and to see you out here relishing this next part of your life after going through something like that. And how amazing are you, David, to be the kind of man that can make that possible?
No, it's not just up to me, as Joe knows. It's the whole team, isn't it? And I think one of the things that we didn't actually talk about very much is that successful patients tend to have, a resilience within themselves and also support from their family and their friends, and that's really one of the critical components of success.
And you certainly had that from your family, Joe.
I did very much so.
Thank you both very much.
Thanks, Callum.
Thanks for
Joe.
having us.
If you want to learn more about SAHMRI and the researchers working to build a brighter, healthier future for you and your family, head to sahmri.org.au.